Today we will demonstrate examination of the eye. The requirement consists of 2 chairs, one for the examiner and one for the patient. It should be adjusted in height so that the eye level of both parties are the same. Equipment required include a functioning pen light, an eye chart, a functioning ophthalmoscope, and cut a bit. With the patient seated facing the examiner at about 2 feet away, and with the eyes of the patient and examiner at approximately the same level, inspect the eye's orbit. There should be a high degree of symmetry between the eyes. Note any asymmetry of position or size of the bony orbit and the surrounding soft tissues. That's the eyebrows and the eyelids. Remember, the eyeball includes the iris and the pupil, and these are readily visible. Note any scarring. Observe for prominence or bulging of the eyes. Examine the eyebrow for hair distribution and the integrity of the skin. The lacrimal apparatus consists of the lacrimal glands with the excretory ducts, the lacrimal puncta, the lacrimal canaliculi, the lacrimal sac, and the nasolacrimal duct. The only visible portion is the punctum. Examine the upper outer margin of the orbit to detect any swelling of the lacrimal gland. Check the puncta on the medial end of each upper and lower eyelid for any inflammation or regurgitation of fluid indicating blockage. Compress the lacrimal sac gently against the inner lower orbital rim or side of the nose for evidence of inflammation or blockage to the nasolacrimal sac or duct. We'll now turn our attention to the eyelids. Of course, we know they're upper and lower eyelids. Inspect the eyelids for one position. And there are many positions. You can notice ptosis or drooping, lid retraction, and in lid retraction, the superior sclera is visible on opening the eyes fully. This is an abnormality. Normally, the superior sclera is not visible. Ectropion, which is turning outwards or sagging of the eye margin, and this is often associated with aging. Note also that in ectropion, there is a constant flow of tears along the medial side of the face. In entropion, there is turning inwards of the lid margin, and the eyelash can cause abrasion of the cornea. Next, examine the margin of the eyelid for any evidence of mucus, pus discharge, redness, scales, or lumps. Note any discoloration of the skin of the upper of the eyelids. In fracture of the base of the skull, the anterior base of the skull, one may note extravasation of blood in the upper eyelid, often referred to as raccoon eyes. Check for lid lag. And this will be demonstrated when we do the thyroid exam, but basically the patient is asked to follow your finger as you move it from superior to inferior, and normally the eyelid and the eyeball are supposed to maintain the same position. Our attention now will be the conjunctiva, and remember, again, you have the conjunctiva over the eyelid and the conjunctiva over the eyeball itself. To visualize the palpebral portion of the conjunctiva, pull down the lower eyelid while the patient looks up, and invert the upper eyelid while the patient looks down. To invert the upper eyelid, ask the patient to look down while the examiner gently pulls the upper eyelashes down and forward to break the suction between the lid and the globe. Next, place the shaft of a small cotton-covered applicator or a Q-tip about 1 centimeter from the lid margin and pull the lid upward using the applicator as a fulcrum to turn the lid inside out. After examination, ask the patient to blink several times to return the lid to normal. You got it? You ready? Examine the conjunctiva for color. Pallor often indicates anemia. Yellow discoloration indicates icterus, and red discoloration, inflammation or hemorrhage. Diffuse redness can be seen in conjunctivitis, uveitis, and acute glaucoma. If inflammation is present, palpate for preauricular and submandibular lymph nodes. Examine for collagen defects. Examine for swelling, which is chemosis, whereby there is fluid accumulation in the episcleral space. Examine for growths, such as pinguicula and pterygia. Examine for embedded foreign body, which may cause redness and pain. Examine for exudates, as often seen in conjunctivitis. We now examine the sclera. Separate the upper and lower eyelids using the index and thumb of your right hand. The index finger pushes the upper eyelid up and the thumb pushes the lower eyelid down. The entire sclera is thus visualized. Examine for discoloration. Yellowish discoloration again indicating icterus, and bluish discoloration, osteogenesis imperfecta. Examine the sclera for hyperemia and nodularity. And the cornea is part of the anterior segment. Other parts of the anterior segment includes the anterior chamber, iris, and pupil. A pen light is used to examine the anterior segment. The cornea is inspected with tangential lighting using a pen light. Inspect the cornea for the presence of rings, white indicating arcus senilis, which is normal in people over 40 years. Greenish yellow rings, Kaiser-Flachner rings, seen in Wilson disease. Examine the cornea for ulceration. Examine the shape of the cornea. Remember the cornea in keratoconus, the cornea protrudes as a cone with the apex becoming thin and scarred. Or examine the cornea for opacities. The corneal reflex will be demonstrated when the cranial nerve function is tested, and the corneal reflection will be covered in more detail on the test for extraocular muscle. Stop. Okay, so we're not doing that yet. Okay. Now let's examine the anterior chamber. A pen light is used to examine the anterior chamber, and the light is projected tangentially. Inspect the anterior chamber for clarity. It should be clear. Examine the depth. By shining the light tangentially, the depth of the anterior chamber can be estimated. Because the iris is normally flat and forms a wide angle with the cornea, no shadow is cast on shining the tangential light. When this angle is narrowed by bowing of the iris forward, thus decreasing the space between the cornea and the iris, a concentric shadow is seen on the medial side of the iris. Examination of the iris and pupils. Examine the iris for the shape. It should be well circumscribed without any defects. The color, of course, the color of the iris varies from individual to individual, and it's related to the contained pigment. The iris may vary from black to brown to blue to one without any color whatsoever. Examine the iris for nodularity and vascularity. The pupil is evaluated for size and shape at rest and pupillary responses. Check for any reflected light showing as gray or silver areas within each pupil. This may indicate cataract formation or in children, retinoblastoma. Examine the size of the pupil. Size difference of less than 1 millimeter with normal reaction to light accommodation is termed physiologic anisocora. Pupil size of less than 3 millimeter is called miosis, and pupil size greater than 6.5 millimeter is called mydriasis. Reduce the ambient light in the room and have the patient look at a distant object. Using a pen light directed from below and just barely illuminating the pupils, inspect the pupils for symmetry in pupillary size. Comparing left and right. Examine the shape of the pupil. Any variation from the surface appearance is abnormal. Now examine the pupil for pupillary responsiveness. Pupillary responsiveness consists of light reaction and near reaction, otherwise known as accommodation. The light reaction should be performed in a semi-darkened room. The patient should be viewing a distant object. The light source should be directed from slightly inferior and upwards towards the patient's pupil. Go ahead. Alternatively, the light source can be directed obliquely towards the pupil. To prevent light from shining directly into the opposite eye to the one illuminated, hold the hand midway between pronation and supination and place the distal portion of the ulnar border of the hand and base of the fifth digit in the hollow of the bridge of the nose. The direct response consists of pupillary constriction of the illuminated eye. The consensual response is simultaneous constriction of the pupil in the opposite eye. You have to look at the opposite eye now. This is repeated in the opposite eye. It means you have to check right. If the afferent arc is intact, the direct response should be equal to the consensual reflex. The near reaction is performed in a normally lit room. Reaction is performed in a normally lit room. Hold your finger about 10 centimeters, which is about 4 inches from the patient's nose. Ask the patient to alternatively look in the distance and at the finger. Observe for pupillary constriction as the eyes converge on close gaze and dilatation as they diverge on distant gaze. Be sure to observe both eyes to confirm the responses are equal and symmetric. Please be familiar with the following pupils. The blind eye, Argyll-Robinson pupil, Addy's or tonic pupil, Horner and Horner syndrome, and the Marcus-Gunn pupil. So we will test the integrity of the extraocular muscles using 4 tests: the corneal light reflex, the convergence of the eyes, the H test, and the cover-uncover test. The corneal light reflex. Shine the pen light directly into the patient's pupil from about 18 to 24 inches away and instruct the patient to look directly at the light. Assess the location of the light reflections and its symmetry on the cornea of both eyes. If the eyes are properly aligned, this reflection is seen as a bright dot on the cornea of both eyes, slightly nasal to the center of the pupil. The appearance should be symmetrical in both eyes. If one eye is deviated, it will be reflected on the dot being seen at an alternate location. A pencil about 1 foot in front of the eyes in the midline. Have the patient fix his or her gaze on the pencil. Move the pencil towards the nose in the midline while the patient continues to look at the object. There should be no movement of the head. The eyes should converge and the pupil should constrict. Now we will demonstrate the H-test. This test can determine which muscles are malfunctioning in a different position of gaze. Examination of the movement of the globe of the eye through the 6 cardinal eye movements is achieved by drawing a large H in the air with the finger in front of the patient's face. The patient follows the tip of the finger with their eyes without moving their head. The finger should be about 18 inches from the nose. Start in mid-gaze and move horizontally to the limit of lateral gaze on the right side. 1 or 2 flicks of nystagmus will define this limit. Move vertically up, then down on the right. Return to the midpoint on the right. Move to the extreme left gaze without stopping to the midpoint of the left gaze. And then move up and down on the left. Pause briefly during upward and lateral gaze to detect the presence of nystagmus. There should be conjugate eye movements without diplopia, which is double vision, throughout this procedure. Okay, we will now demonstrate the cover-uncover test. And this is to determine whether there is any occult misalignment. Remember, there are 2 types of ocular deviation. One is known as atropia, also known as strabismus, and the other aphoria. Atropia is a constant misalignment of the visual axis of both eyes, and what happens when you look at the eye, they cannot point in the same direction. Aphoria is a latent deviation held in check by fusion, and the cover-uncover test is really to determine the presence of aphoria. With strabismus, it tends to be obvious and no test required. Okay, ask the patient to fix his or her gaze on a small, distant object, such as looking over the examiner's shoulder. Observe the patient's eyes. They should appear aligned. If they appear misaligned, there will be typically one eye that fixates and the other eye will either deviate outward, exotropia, or inward, esotropia, or upward, hypertropia. In situations where the eyes appear aligned, one eye is covered for 20 seconds. And then removed after 20 seconds. The covered eye should maintain its position. But if there is weakness of one or more extra muscles on that side, the covered eye will have drifted in esotropia or out esotropia. After uncovering that eye, a rapid refixation movement is observed for that eye to regain conjugate gaze. Check the opposite eye in the same way. We will now examine the lens. Examination is done with oblique lighting, and the lens is examined for opacification, often called cataract, which may be related to trauma, or it may be present in congenital abnormalities such as Down syndrome and cretinism. examine the position of the lens, whether it's in a normal position or dislocated. We will now perform visual acuity, better defined as central visual acuity. In the laboratory, we will measure visual acuity using the Snellen chart. However, for this demonstration, we are going to use the Rosenbaum chart. Please remember, in the Snellen chart, you stand 20 feet away. In the Rosenbaum, you stand, the chart is 14 inches away from the person. The patient is asked to cover each eye in turn with the palm of his hand and read the lowest or smallest type line on the chart that is possible. So he covers one eye, the other eye use the smallest type that he can see.
639. 42.
If a patient correctly identifies more than half the letters on the line, the visual acuity attributed to that line is considered his or her visual acuity. If a patient wears corrective lenses, the visual acuity should be repeated with these in place. In recording visual acuity, the following abbreviations are used: OD, right eye; OS, left eye; and OU, both eyes. If the patient cannot read any of the lines, then their ability to count fingers held up in front of each eye with the other one closed, or perceive light by turning the light on and off and directed in each eye is tested. No, you don't have to use finger if he can see the type. Testing visual field. The most common methods are by confrontation and by perimetry. The third is electroretinography. In this lab, we will demonstrate the technique by confrontation. Confrontation method. This is usually carried out with both eyes open, and then alternatively with one eye closed and the other open. The examiner and patient should be at the same eye level, sitting or standing, directly in front of each other, about 2 feet apart, and the patient's eyes fixed on a target, such as the examiner's eyes or nose. The examiner returns the same gaze. There should be no movement of the head, and the room should be properly lit. Assess the temporal fields of both eyes by asking the patient to indicate when he or she sees your moving fingers as you bring them forward in the horizontal plane from behind the lateral margin of the orbit. The finger should start from outside the peripheral field of vision at points behind an imaginary circle with both ears on the circumference. Repeat this for the upper and lower temporal quadrants. If one eye sees your finger significantly before the other, assess each eye separately to ensure that there is no cortical extinction in the weaker eye. To assess the nasal field, the examiner covers one eye, examines his left eye with his right hand, and the patient covers his right eye with his right hand. Using the hand on the same side that the examiner covers, that means using his left hand now, the nasal field of the left eye is examined. Bring your moving finger along the plane of the midpoint between you and the patient in each of the vertical and nasal quadrant, and assess whether the patient sees the finger at the same time as the examiner. Repeat by testing the other eye. Examination of the eye is examination of the retina. Reporting the ophthalmoscopic finding, one must report on the retinal vessels, the background retina, and the optic disc. Reduce the ambient lighting in the room. A dark room is preferable. Ensure that the ophthalmoscope is working correctly. Turn the light on and switch to the small aperture if the pupils are not dilated, as is the case in this situation. Turn the light intensity down as far as is compatible with seeing the red reflex. Start with the lens diopter dial set at 0 unless examiner uses corrective lens. If you use spectacles, remove them and adjust the diopter setting to correct for your visual acuity data. Contact lens should be kept in and leave the diopter setting at 0. Place the instrument in front of one eye with the cushion bar pressed firmly against your eyebrow. Hold the ophthalmoscope with the right hand in front of your right eye to examine the patient's right eye. The opposite is true to examine the left eye. Extend the index finger of the hand holding the ophthalmoscope to rest on the lens wheel. This is used to change the diopter of the lenses. Start the examination about 1.5 to 2 feet from the patient and ensure that you examine the patient's right eye with your right eye and the patient's left eye with your left eye. Ask your patient to focus on a distant spot over your ipsilateral shoulder and to avoid looking directly at the light. Observe the red reflex in the pupil of the eye to be examined. This will not be seen if the path of the light is obstructed by opacities such as cataract. At an angle of approximately 15 degrees from the sagittal plane, approach the patient at eye level. Use the thumb of the opposite hand to gently elevate the eyebrow of the eye being examined. While maintaining the light on the pupil, move in close until the hand holding the ophthalmoscope rests on the patient's cheek. At this point, either a blood vessel or the optic disc should be visible. Use the lens wheel to adjust the diopter, plus or minus, to get this vessel or disc in clear focus. The minus lens, which is myopic, are usually in red, and the plus lens, hyperoptic, in black or green. If a vessel is seen, follow it to the optic disc. The size of the vessel increases as you move towards the disc. Do not turn the instrument to follow the vessel, as you will move the light away from the patient's pupil. Move your head under ophthalmoscope as a unit. Observe the optic disc and cup. Follow the vessels to each quadrant of the retina, noting the state of the arteries and veins and the background appearance of the retina. When this is complete, ask the patient to look directly at the light. Observe the macula and fovea. Note that the macula is temporal to the optic disc. Hold the ophthalmoscope with the other hand and repeat the above steps and examine the other eye. You gotta go in till your hand touches. Normal fundus should be free of hemorrhage. Any yellow, white, gray, or black interruptions of the background retina are abnormal and suggest exudates. This completes the examination of the eye.